So for those of you who don't know, my name is Christine McWilliam, and I'm with the Alzheimer's Society of Alberta and Northwest Territories. I'd like to welcome as well my tech support, who is Jennifer Sims. She's online with us today should you have any questions or need any assistance in that area. So I'd like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nation people that call this land home and endeavor to move forward in a spirit of reconciliation and collaboration. So just a couple of housekeeping items before I hand it over. I'd just like to note that we are open and that some of us are working remotely, but if you should need our services or need to refer anyone to our services, please do so. We are accepting referrals. I'd just like to say thanks again for people coming out this afternoon. I know everyone's maybe a little tired of the virtual space, but we really do appreciate your support and your time to come out and hear what our presenters have to share. And also, please let us know of any feedback. If there's anything you'd like to hear about, topics in the future, there will be a survey at the end, which everyone loves. We are offering these healthcare professional outreach webinars bi-monthly, so the next one will be in April. So please keep an eye on your emails for the information on that one. Just to remind people, we are recording, and this will be available after on our Assant Cafe for viewing. Today we will use the chat section or the Q&A. The Q&A, you can submit something anonymously if you'd like, or the chat can be to everyone, your choice. We are open to unmuting people to talk with their mics, but please just raise your hand and let us know that you'd like to use that function. And finally, I would just like to say, like I'd said, that we do have about a 5-minute survey that will pop up at the end of this, and it will also come in your follow-up email tomorrow. We would really appreciate if you could take the time to fill that out for us, because it does help inform us of future webinars to offer folks that people find interesting and engaging, and we're always looking at developing this better. And without further ado, I will introduce our speaker and then let her have the floor. So Dr. Jana Holyrood-Leduc is an academic geriatrician, professor and head of the Department of Medicine at the University of Calgary and Alberta Health Services, Calgary Zone. Her research utilizes knowledge translation science to improve care for older adults. She is the U Calgary Brenda Stratford Foundation Chair in Geriatric Medicine and the academic lead for the U Calgary Brenda Stratford Centre on Aging. She plays a leadership role within the Canadian Frailty Network. And so Dr. Holyrood-Leduc, if you'd like to unmute yourself and share your screen, that would be great.
So good afternoon, everyone. Thank you for inviting me to present. I'm going to present some research that I recently did in collaboration with a number of different individuals. And so I'm going to present the results of this research and also at the end touch a bit on sort of some next steps we have gone on to do as a result of what we learned from this research. So specifically, I'm going to talk a bit about today optimizing supportive end-of-life care for frail older adults living with dementia in long-term care. So just to start with my disclosure, this project was funded by the Canadian Frailty Network in the form of grant funding, as well. The chair I hold from the University of Calgary, the Brenda Stratford Chair in Geriatric Medicine, funded the postdoctoral fellow who did a significant amount of work in this project. I've tried to make this presentation copyright compliant, and I'm also going to aim to use person-first and inclusive language. However, if you find ways that you think I could improve, feel free to send me an email after the presentation. So the two main sort of learning objectives I'm hoping you'll take away from today is twofold. One is to be able to describe the challenges that are faced within long-term care around providing supportive end-of-life care for frail residents within the last year of life, and also to understand evidence-based approaches to providing supportive end-of-life care within the long-term care setting. So some background, about 30% of Canadians over the age of 85, which is currently about 150,000 people, although that number is increasing as our population continues to age, currently live in long-term care or similar residential care settings. And it's projected with the aging of the population that we're going to need another 200,000 new beds by 2035, so in just over 10 years. The care that's provided in these settings is by a multidisciplinary team that includes healthcare aides, nurses, physicians, allied health, and also family members. Long-term care residents as a population are often living with frailty, which includes having impairments in their functional status as well as in their cognition. And as such, they often require assistance with activities of daily living. And we know that the prevalence of dementia or cognitive impairment among this population is about 80%. They often have complex health and care needs and are typically nearing the end of life. So about a third of long-term care residents in Alberta have a comfort level goals of care. And we also know from other data that came out of other research done in Western Canada that most people in Western Canada living in long-term care have an average life expectancy of somewhere around 18 months. So people living in long-term care have a high prevalence or a high burden of symptoms such as pain, as well as other dementia-related responsive behaviors. About 40% of Canadians actually will die in long-term care. Therefore, enhancing end-of-life care within long-term care should really be a priority in Canada for all of these reasons I've outlined: the aging of the population and the care needs and the symptom management of this population. We really need supportive end-of-life that focuses on symptom management, so both physical, but as well psychological and spiritual symptoms, as well as maintaining quality of life and having appropriate conversations around advanced care planning, and then supporting not only the patient or the resident, but also their families through this process. Unfortunately, there's a number of barriers to providing supportive end-of-life care within the long-term context in the Canadian setting. Some of these include communication barriers related to dementia and the high prevalence of cognitive impairment. Some of it relates to the unpredictability around the dying trajectories related to frailty. As well, in society, there's lots of barriers to discussing dying. In long-term care, there's currently high workloads. As well, to some degree, there's limited palliative care knowledge and skills, at least from a formal basis. And so we tend to have an over-reliance traditionally on acute care resources as a result. There's a number of inappropriate care practices that also exist in a number of long-term care settings. These include inappropriate prescribing, in particular, the overuse of antipsychotics, which unfortunately we've seen a rise after much work to try to decrease this in long-term care. This has again risen as a result of the COVID pandemic and the challenges brought on by it. As well, we tend to use physical restraints when we probably shouldn't be. And there's tends to be an overdependence on the emergency department for transfers when there's an acute change in someone's status. So the objective of this study I'm going to present you the results on today, we're around exploring physicians' perspectives on delivering supportive end-of-life care within long-term care, including looking at barriers and facilitators. The main reason we focused on physicians is when we looked at the body of evidence, there really had not been a lot of exploration around what the physicians felt the barriers were. It had been looked at from a nursing perspective and other perspectives, but not so much from physicians. So we wanted to include this perspective. And then the second fold was to actually prioritize evidence-informed end-of-life care practices and tools that were targeted to addressing the known barriers, both from our what we learned from our physician survey, as well as from the literature in order to develop an end-of-life care strategy that would be applicable within long-term care. And we did this through engagement of all long-term care team members, including family members. So the role of the physicians in long-term care is really to address complex care issues that are being faced by the long-term care residents. So that's medical, both acute and chronic, cognitive, mental health, and also functional issues. And they really play a leadership role in supporting the end-of-life care team within long-term care. Yet all we really know about is or we know very little about the perspectives and experiences of supporting end-of-life care and long-term care from the standpoint of our family and palliative care physicians who are working in this context. So what we wanted to do for the first part of the study is actually to conduct a descriptive qualitative study. Specifically, we conducted semi-structured telephone interviews, and we analyzed these interviews using a qualitative content analysis approach. So specifically, we used the Michi theoretical domains framework, which I'll chat a little bit about as we go along. We transcribed the transcripts from the interviews and coded them and themed them by one of the researchers, the postdoc. And then we confirmed the codes by a secondary researcher and themed them overall with the research team. What we ended up, in terms of interviews, we ended up with 23 family and palliative care physicians that were working in long-term care from right across Alberta that participated in this part of our study. And here's the physician participants. So 11 were female. They ranged in ages from 30 to over 60. Many of them worked within the primary care networks. They'd been in practice for duration, a variety of lengths and duration, from less than 10 years up to more than 20 years. And they worked across the province. So a number worked in large to median size communities. However, we also had several in small or rural communities participate in the surveys. So what the questions focused on in these surveys were multifold. So we wanted to get the perspectives of the physician's role in managing supportive end-of-life care. We also wanted to inquire about their experiences of working with other long-term care staff providers in supporting end-of-life care. We had questions about resources and services currently being accessed to care for older adults living with frailty near the end of life. And then we wanted their input on suggestions for enhancement or improvements that could improve the provision of supportive end-of-life care delivery in long-term care. So from an analytical perspective, as I said, we use the Michi's TDF, or theoretical domains framework for behavior change. And this is a well-known behavior change theory that divides types of behavior down into 14 different areas. So it's based on psychological theories of known human behavior. And so you can design an intervention to actually make sure you look at all the different potential interacting factors of human behavior that can impact why something is or is not done. This further can then be sort of summarized down into something called the COM-B, which you can see from this picture. The COM-B stands for capability, opportunity, and motivation, which are the three main drivers of behavior change and are areas to look at when we're thinking about how would you design an intervention to actually change behaviors. So specifically, motivation looks at factors that shape perceptions, experiences, and behavior. Opportunity looks at factors in the environment, both the physical and the social environment that influence behavior. And capability looks at an individual's knowledge and skills that may enable or even prevent them from participating in a desired behavior. And so our analysis of our interviews were guided by this framework to help us best understand what types of behaviors would be barriers to actually improving supportive end-of-life care provision in long-term care. So in terms of identified barriers from our physician interviews, there was three main themes that we came up with. So one was managing expectations of frailty and care management. The other was dealing with psychological and spiritual concerns. And the third was complexities associated with end of life. And I'm going to touch briefly on all three in a bit more detail. So in terms of managing expectations of frailty and care management, there was uncertainties related to pain assessment. And so when we looked at them from perspective of the COM-B framework, from a capability behavior, there was a barrier in terms of experience challenges in distinguishing when confusion may be related to pain among people that had underlying cognitive issues. In terms of a capability and opportunity barrier, there was concerns of finding it challenging to depend on nursing staff to observe and document pain. So the feeling that nursing staff may lack skills or even more so time to use available pain tool assessments. And that also similarly, nurses were having challenges in documenting pain. And then there was a motivation factor too, in terms of at least the physicians felt the perception of long-term care nurses in terms of them being vulnerable to burnout. So concerns that this could impact their ability to provide compassionate care, given the recognized overburden of care providers within the system. Other issues around managing expectations of frailty and care management were uncertainties related to using medications. So from a capability, finding it difficult balancing the use of medications to relieve symptoms, in particular pain, with managing side effects, particularly in older adults that were living with frailty. So a lot of medications that are used to relieve pain symptoms can contribute to confusion. So there was concerns around balancing that. In terms of capability and motivation, they found that some staff were inexperienced or uncomfortable giving narcotics to patients near the end of life. And an opportunity was concerns about complying with narcotic prescribing policies of the provincial colleges of physicians and surgeons. So, wanting to use appropriate narcotics to address pain, but not, having their practice of prescribing being flagged by the college as being inappropriate. So that was a concern that physicians had. In terms of dealing with psychological and spiritual concerns, the main barrier fell into opportunity. So it was difficult overall to access needed psychological and spiritual services within the long-term care context. So there was limited in terms of the scope and capability, and particularly for persons with psychological concerns that were not related to dementia. This was recognized as a significant barrier. In terms of complexities associated with end of life, so knowledge and skills concerning care management was a subcategory. In terms of capability and motivation, the physicians felt families can find it difficult to accept end of life and the limited treatment options that were available to the older adult living in long-term care. Opportunity in terms of intensity of care increasing at the end of life, but really long-term care staff ratios staying the same. So this whole inappropriate mix of needed resources at certain times in the stages of end of life. In terms of capability and opportunity, long-term care staff did seem, from a physician perspective, to be uncomfortable or unprepared or even unsupported to provide end-of-life care. So that was seen as a barrier. In terms of complexity of associated end-of-life care, when it came to other knowledges and skills, there was an opportunity in barrier in terms of opportunities, in terms of difficulties in accessing community resources. So particularly psychological services, chaplaincy, and social services. As well, there was limited private spaces for the residents and their families at the end of life. A capability and motivation barrier was resistance among some physicians and long-term care staff to learn or integrate palliative care practices within this population. There was some facilitators identified though as well. So they were three main themes: utilizing standardized tools to set expectations, utilizing available resources, and providing specialized training for physicians and long-term care staff. So in terms of utilizing standardized tools to set expectations, there was a need to have goals of care conversations early and at the end of life. So that was seen as a facilitator. Another facilitator was utilizing standardized assessment tools throughout the admission right up to end of life, particularly frailty assessments and pain assessment tools. In terms of utilizing available resources, opportunity around accessing chronic pain specialists, as well as palliative care consultants and community paramedics. There was also an opportunity in terms of changing the environment to meet the residents' needs, and an opportunity in involving the residents in meaningful recreation activities. So inviting recreational, volunteer, and community service groups to organize activities for the residents. Remember this, I should have outlined this study was done before the pandemic, and I recognize that some of this particular facilitator may not be so easy to facilitator in our current context. In terms of providing specialized training for physicians and long-term care staff, they felt that giving and receiving education and mentorship in palliative care was a facilitator. So having knowledge and skills development and building competence and confidence in providing end-of-life care was a facilitator to providing end-of-life care to residents in long-term care. So essentially from the interviews, we had sort of three key messages that we thought came out of it. Is one was supporting end-of-life care for frail individuals is complex and unpredictable, yet families do expect some degree of clarity and certainty. Two was that there was a need to provide education, training, and mentorship and collaborative supportive care and long-term care. And then third, there was a need to provide access to palliative care and other community resources needed to provide supportive care in long-term care at the end of life. So the next part of this study was we actually wanted to look at what was the evidence around interventions for providing end-of-life care and long-term care. So specifically, we conducted a systematic review where we looked to answer the question, what is the evidence for support of end-of-life care interventions in long-term care? So using the PRISMA technique, we conducted the systematic review, identifying 25 published intervention studies. Overall, the quality of the studies was low quality evidence. And the most common design was just a pre-post, so a low quality study design. There was one moderate quality randomized control trial of just over 205 patients that focused on the access to palliative care. Interventions identified did align, though, with the physician-identified barriers and facilitators, which was a bit reassuring. So these are the main findings from this systematic review in terms of what kinds of interventions have been shown to be effective. So the first one was providing access to palliative care consultants, which had low to moderate evidence. The second was engaging residents and families in discussions about goals of care, treatment preferences of palliative care, which had low to moderate evidence. Three was early identification by long-term care staff of residents whose condition had deteriorated and who appeared to be at high risk of death, and then communicating this to the attending long-term care physician in a timely manner, although the evidence for this was lower. Fourth was providing long-term care staff, so healthcare aides and nurses specifically, with education and training about how to provide supportive end-of-life care. The evidence around this, though, was low to very low. And then the last thing identified from the systematic review was increasing access to spiritual care services, which, though, had very low evidence. So moving on from this, having sort of looked at the potential barriers and facilitators to end-of-life care and looking at what evidence was around what types of interventions should we be doing in long-term care to provide good supportive end-of-life care, we proceeded with conducting what's called a modified Delphi procedure. And I'll walk you through sort of how we did this and why we did this. So for the modified Delphi, we conducted 2 rounds. So what we did is we took a purposeful sample of stakeholders from across Canada. So we had 65, including physicians, long-term care staff and administrators, long-term care residents and family members, and then also palliative care and geriatric gerontology experts and researchers. And the process we followed for the modified Delphi is we had a questionnaire developed from the physician interviews and our literature review. The Delphi participants were asked to rate 75 statements based from the results of the interviews and literature review. They were asked to rate them on a 9-point Likert scale. And our threshold for the appropriateness of inclusion was a median score of 7 or higher. And then sort of statements overall aligned with sort of 4 subheadings or subtypes. So managing pain and other symptoms, managing end of life, long-term care context, and topics related to families. So the results of our Delphi. So for round 1, out of the 65 participants, we had 18 people participate. They were a diverse group from across 3 provinces. Only 4 of the statements that we asked them to rank scored either less than 7 or sort of between 7 and 3. The remainder and so those 4 remained for further clarification in round 2. Out of the other statements, they all rated above a score of 7, so met inclusion based on round 1. In round 2, we had 11 participants that had participated in round 1 re-participate, and it was decided that the remaining 4 statements that were not clearly needed to be included in our ending Delphi statements should actually be excluded. So what did we actually find? What statements, based on the literature and based on this Delphi, what were the important things in terms of what would be important in managing supportive or providing supportive end-of-life care to long-term care residents? So the first category was around managing pain and other symptoms. So the ones that ranked the highest were the statement that among persons with dementia, it was important to include the family when trying to understand a patient's responsive behaviors. That scored 9, so the highest score. Another high scoring one was among persons with dementia, it was important to identify the underlying factors associated with the patient's responsive behavior. So, why were they having aggression, or why were they calling out, for example? And then there was other statements that ranked above 7, so each scoring 8. So accessing access to technologies within long-term care that could help facilitate supportive end-of-life care. Occupational therapy involvement is helpful for identifying and addressing functional changes throughout long-term care admission and end of life. And then recreational activities such as gardening, caring for plants and animals, telling stories, and hearing children sing are helpful for managing pain and anxiety. Other things around managing pain and symptoms, other statements that were came out of the Delphi was that medication choices within long-term care should focus more on pain and symptom management and less on longer-term preventative strategies. Having end-of-life order sets can help guide supportive care decision-making once the patient was identified as needing palliative care. Inconsistencies in how different long-term care facilities charted symptoms can make it challenging for physicians and other healthcare providers that work within multiple different long-term care facilities to care for residents. And then the other statement that stayed in from the Delphi was inconsistencies in how different long-term care facilities charted symptoms could make it challenging for physicians and other healthcare providers that work in multiple settings to communicate with other teams. So both the differences between sites and how they charted was a barrier to provision of care and to communication. In terms of the heading of managing end-of-life care, one of the key statements, which also is underlined here because it was also one of the ones where there was evidence of this being an effective intervention from our look at interventions, was engaging residents and families in discussions about goals of care, treatment preferences, and palliative care. Needs can improve end-of-life care outcomes. Other ones that scored high in terms of managing end-of-life care: a collaborative approach to care improves care by improving communication between team members. A documented palliative care pathway helps to identify changes in patient status, manage family expectations, set staff expectations, and organize the provision of care. And then it's important to have private spaces within long-term care facilities for patients and families at or near the end of life. Other statements that remained in, that scored a little less, but still high enough to remain in, was it's important to determine and include family expectations in care decision-making and to not rely exclusively on standardized care management protocols. The care needs of residents increases as they reach the end of life, yet overall staffing levels remain the same. And then similarly, this underlying statement was one that was found in our literature search that timely identification by long-term care staff and residents of when a resident's condition deteriorated and or if they appeared to be at high risk of imminent death, this needed to be communicated to attending long-term care physicians to improve outcomes at end of life. Our other heading in terms of the context of providing supportive end-of-life care within long-term care. So some of the high scoring ones. So providing long-term care staff with education and training about supportive end-of-life care improves end-of-life care practices. And they said this was also a statement intervention that came out of our systematic review as well. Access to palliative care consultants improves the provision of end-of-life care, also coming out of our literature search. And then the other ones that all scored 8 as well were by working with palliative care consultants, long-term care physicians learn to utilize palliative or supportive care principles and practices to treat symptoms and care for residents from admission to end of life. Highlighting positive stories about supportive end-of-life care provided within long-term care could help change public perceptions about the quality of care provided within long-term care. And then the last one, senior management within long-term care facilities can dictate how supportive end-of-life care is prioritized within their facilities through policies and procedures, as well as by influencing the culture. So our last main heading was around topics related to families. And so the main statements, the highest rated statement was it was important to involve families in conversations about care. Other important statements were families' misperceptions of outcomes can make it challenging to meet their expectations of supportive end-of-life care treatments. As well, families' misunderstandings of supportive care in long-term care causes them anxiety, worry, and confusion. Involving palliative care consultants can help improve family members' understanding of supportive care, including helping to manage family expectations. Family values are factors that determine the level of care provided. Goals of care assessment tools help physicians manage care expectations and create care plans with family. And families can be helpful when determining goals of care, given their intimate knowledge of the patient's goals and values. So what we did after this, conducting sort of our interviews, our literature search, and then combining it all into these Delphi statements that sort of create sort of what would be important to consider when providing long-term care. We wanted to bring all this back to a variety of long-term care stakeholders. In particular, we held an in-person consensus meeting. At this meeting, we presented the results that I presented you today, the qualitative study, the systematic review, and the results of our Delphi. The goal of this meeting was to prioritize supportive end-of-life care practices and to try to begin to develop sort of an accompanying implementation strategy. We had 35 participants at our consensus meeting, and they were from a variety of different stakeholder groups. So we had physicians, nurses, healthcare aides, and other providers. We had content experts and researchers. There were healthcare administrators present, and we had family members of long-term care residents also present. The consensus meeting used World Cafe discussions where people went from table to table and built on discussion. So everybody had opportunities to participate in our 4 main areas, which were managing pain and other symptoms, managing end of life, looking at the long-term care context and topics related to family. So all consistent with our areas from the Delphi. And from all of this, from these consensus meeting and building from what we learned from our other parts of the research, we actually developed this supportive end-of-life care strategy in long-term care. So at the center of it was improving supportive end-of-life care within long-term care. And there was really felt to be, based on all what we'd learned, 6 things to focus on. So first was the need to restructure the physical setting within long-term care. The second was the need to provide education and skills training of those working within long-term care about the provision of supportive end-of-life care. Third was to build collaborations between the different care providers that were involved, including the family members. Fourth was then really the big need to conduct a media campaign to change public perceptions of long-term care and expectations around long-term care. 5 was involving families in care discussions and being sure to respond to their concerns. And then 6 was really broadening the definition of what a frail older adult or an older adult living with frailty was, to really reflect the fact it's diverse in terms of the health conditions that the person may be living with. So coming out of this, the key recommendations that we had were to, 1, create policies and provide funding for extra staff and comfort care needs at the end of life to realize this strategy. The second was to establish knowledge and training expectations and resources for staff and physicians, focusing on palliative approaches, mentorship, communication, and collaboration in long-term care. And I'm going to share with you a project we're doing that's actually focusing on this particular recommendation. And then the third was building connections between long-term care and the wider community around challenging public perceptions of long-term care. So for this project, I just want to acknowledge, once again, I acknowledge the funding at the beginning, but I do want to acknowledge it was a team effort, a large team. And so the postdoctoral fellow hired that did a lot of the work on this project was Dr. Patricia Hersham. However, I had a number of co-PIs, including Dr. Lorraine Venturata from the Faculty of Nursing and Dr. Ayan Sinaraj, who's a palliative care physician. And then we had a number of investigators from across Alberta and the province. So I just want to touch briefly sort of in terms of our what I said of number 2 and work we're doing to kind of now operationalize what we found. So specifically, we're working on developing a frailty care pathway within long-term care. So this is being led by myself and Dr. Zara Gadarzi, who's also an academic geriatrician here at the University of Calgary. So we've developed a clinical care pathway for older adults living with frailty and long-term care. It was developed by funding that we got from the CHR, and it used evidence from this project along with evidence regarding sort of ways to evidence around detecting frailty, diagnosing it, and managing it. This project also conducted a modified Delphi process to help us develop the pathway, and we've resulted in a frailty pathway for long-term care that focuses on strategies to delay progression of frailty, looks at early palliative care to manage symptoms, and also looks at end-of-life care as appropriate. So we're in the process now of implementing this frailty care pathway. We have funding from Alberta Health in their PLOT grant program. We've explored potential barriers and facilities to implementing this specific pathway. So we interviewed care providers, residents, and families to get a sense of that. And we're using something called the query implementation strategy, which essentially we're starting right now in the middle of a pilot implementation at one site to see how the pathway is actually practically implemented, and learning from that and adapting our implementation strategy. And then using the funding from Alberta Health, we're expanding it to facilities across Calgary and hopefully eventually across Alberta if it's successful. Our implementation, we have an implementation coach, specifically a geriatric clinical nurse specialist, who's helping guide the implementation using a train the trainer education model with the educators and other leaders within long-term care. We also have some printed point of care resources for care provision. And we're developing our implementation strategy to address the identified barriers. We're going to have a robust evaluation using mixed methods, both quantitative and qualitative evaluation. We're going to consider sort of all the different dimensions of quality. So using the Health Quality Council 6 dimensions of care. Specifically, our primary outcome is looking at a change in the uptake of frailty assessment for older adults. So that's our effectiveness outcome. And we're also going to look at how successful were we at actually implementing using something called the REAIM framework, where we'll look at reach effectiveness, adoption, implementation, and maintenance. And then we will do a cost consequence analysis of this pathway. And that is what I wanted to present today. And I want to open it up now for questions and discussions, and I will stop sharing.
Excuse me. Thank you very much for sharing all of that fascinating information. I do see you already have some questions in the Q&A portion. So if you want, I can go through them and moderate them a little bit for you if you'd like.
Sure.
Okay. So the first, it looks like kind of couple questions are, what are your thoughts around the new long-term care service standards specific to Alberta? And did any of your research or Alberta research go into the standards?
So I wasn't actually specifically approached to give any input in the new standards. I don't know if they use my research or not. It is published, and it's been published for a few years, so I'm not sure if it went, to what degree. And so I think there is a lot of work overall that's happened. So just specifically, touching on Alberta Health has this PLOC a grant program that's actually focusing on end of life, and a lot of the projects that they funded, in addition to ours, do focus in long-term care and end of life. So I actually think there is a lot of important work. So, did maybe my research help to draw some attention to this issue and research of what's going on by others? And because I do think, since we did this research pre-pandemic, and maybe the pandemic also played a role, this is a bigger focus in long-term care, and there is important work going on. So, I don't know if that answers your question, but I think in Alberta, there is definitely been a commitment to look at this in long-term care and to better support end-of-life care and long-term care.
Yeah, absolutely. And I think you're absolutely right that the piece, if COVID has highlighted anything in so many different capacities and so many different lights, that long-term care definitely needs some changes to it. So it's great to see this type of research, and hopefully it does go far in creating a positive change. So I work in long-term care. How do I start to implement some of these changes, especially in the end of life part?
So I think, I'm not sure where this person works, but like I said, we do have this pathway that we're trying to implement, where we're looking at considering, the impact of frailty and sort of working to, slow the progression of frailty, but also make sure we're addressing symptom management and providing appropriate end-of-life care. So I'm hoping that this pathway will learn a lot as we implement it, and be able to actually scale it up and spread. So hopefully it will eventually become part of standard of care within long-term care, in terms of ways to implement a lot of what this pathway does build on what we learned. In terms of from an individual basis, I would say, taking up every opportunity you have to develop your understanding and skills in, palliative medicine, in terms of how do you provide supportive end-of-life care. I don't know the role in long-term care, but, based on your role, how do you help with, there's lots of ways to address the symptom burden that people living with frailty and long-term care are experiencing. And, how can it's not all pharmacologic. A lot of it actually, the most effective things is non-pharmacologic. So learning strategies to provide good supportive symptom care, learning about, there is, opportunities as a care provider. I believe Asant's been involved in this, but some work by Jasmine Palmer and others at U of A have led around a curriculum for healthcare workers on how do you actually provide not only patient-centered care, but family-centered care. And so they've got a number of modules. So, in terms of, because I think we did learn, it's very important. The family is really, this, long-term care is where these residents live. It's not sort of like a transient visit to a care, a healthcare facility. It's where they live. The families are actively involved. They're important care in the care provision. So learning, I would encourage you to take some of those modules. They're all online. Around how do you actually effectively interact with and provide family-centered as well as resident-centered care. So that I guess definitely the evidence in terms of effective interventions and sort of what we found is a good starting point is having sort of some basic knowledge and skills, as a starting point, for sure. And that is something an individual could do on their own.
Yeah, absolutely. And it's interesting that you do mention that, because we were, as I'd mentioned earlier, we're planning for some fall webinars for 2023, and Jasneet and her team had come up that they would be a great one to highlight their modules and how they could be utilized by staff working in long-term care. So yes, thank you for mentioning that. Have the final results model been implemented into any long-term care? Is there any plans for it? I feel like you kind of answered that one to some extent already.
Yeah, I don't know about if others. I said it's all this is all published, and so people could take the model and use it. But like I said, we're trying to take it to the next level in terms of our pathway, our care pathway.
Yeah. Okay, you have one more question, but please, if there's anyone else who have any other questions for our presenter, to just put them into the chat or the Q&A section. Who will all get these recommendations?
So we actually published them in the peer-reviewed literature, but also created a document that we distributed to everybody that participated. So it went out quite broadly about our process and our recommendations and the pathways. And we've also presented it to a number of different audiences, both sort of across Canada in terms of people that are working in, doing research and working in this area, but also locally too. So, that we developed some decision aids in that too, that has been, so there is a report that has been distributed. Like I said, that to some degree can be effective. So that's why we're going to the next. I think it's more effective though that we actually develop sort of the next stages, which we're doing is how do you actually implement these changes? So which is why the pathway, and I think the pathway we've developed could definitely not only be implemented in sort of more urban, suburban facilities, but also potentially in rural care facilities, because it's built in a way that doesn't necessarily require resources outside of what's available within the long-term care setting.
Right. Well, and that kind of goes to this person's second point about how does it get into rural care homes as well? Because I mean,
Yes.
that poses its own separate set of challenges right there. So, and then another question just popped in. When you're saying end of life, how close to end are we talking about? And I think that's really important to acknowledge, because that can mean a lot of different points for a lot of different people, for a lot of different family members, for a lot of different points of entry to care.
Yeah, so that was a definitely a point of discussion about what, and even just the difference between talking about end of life and palliative care. So, just to give some context, palliative care now is often, traditionally I think it was seen as sort of equivalent to end of life, in the last, palliative care services sort of in the last days to week, but palliative care has moved away to more focusing on symptom management. And so often palliative care services gets involved, when someone is not just imminently dying, in terms of managing symptoms. And so, we called this more end of life because we were thinking more, so it doesn't mean imminently dying within hours to days, although it could, but we're thinking end of life in terms of, within terms of weeks to months. So, definitely wouldn't be years, recognizing that, there is evidence coming out of primarily from TREC work, the TREC group that does research across some long-term care in Western Canada, that showed the average life expectancy of long-term care being 18 months. So, I think for our project definition, we felt that, less than 18 months is probably what we're talking about, because of the ability to actually intervene if someone had significant frailty and associated symptoms, and participating in these goals of care discussions and other things, so they didn't have to be imminently dying in terms of end of life. That's how we had defined it, in terms of thinking about quality at end of life, if that answers the question. And also to keep in mind that the issue with, when you look at sort of trajectories and predicting end of life, first off, healthcare providers are actually notoriously not that good. But sort of probably at least traditionally before sort of some of the really advanced cancer treatments, cancer used to be probably, the trajectories of cancer, people would get diagnosed and die relatively quickly. But we know with, that's changing to some degree because of changes in therapies, but we know with both frailty and also people living with complex comorbidity, they tend to will have acute declines, then they can have, with some interventions, recover to some degree and have some more quality of life. And so, the path, it's not a direct pathway in terms of, knowing exactly what, how much time somebody has, because you're not sure where they're at in terms of, is this an acute decline that actually they'll have some recovery from, or is this actually sort of that they'll continue to progress into the ultimate end of life care. So it's a little bit predicting where, end of life when someone's living with frailty and complex comorbidities actually can be challenging, and often don't know. So I think we wanted to focus on end of life in terms of how do you support quality of life, making sure you're providing the care the person would want and managing symptoms.
Yeah, absolutely. I think that's of course, it's a really great answer, just because definitely, as you had said, I don't think that long-term care is always necessarily the best at identifying when that stage is happening. and then what to do with it moving forward on an individual person-centered basis. See, just one more question popped in. I'm just going to kind of summarize. Are you facing any barriers with implementing this research?
I mean, we always try to look at barriers in terms of when we actually have a night, like sort of as I walk through, there's implementation to any kind of research. There's we have people are complex and we have to look at sort of human behavior and what potential barriers. So we always try to be thinking about that, and so and be proactively trying to design our implementation strategies to address what we think will be the barriers, but being very sort of what we call iterative and always trying to be mindful of new barriers. So, I mean, definitely funding, although I must say, Alberta Health did just commit a lot of funding to look at that. So that the timing of that for us was quite well. We were able to take advantage of that, and we did get some national funding. So CHR is national funding, as is the Canadian Frailty Network. So funding, I would say, somewhat of a limitation in terms of funding to broadly scale it up and spread. That will be probably a bigger issue, right? It's one thing to do these smaller scale and to learn. And definitely, I think, in terms of implementing effective supportive end-of-life care, within long-term care, we know long-term care, particularly with the pandemic and staffing challenges, are challenged to provide the level of care that they ideally would want to, I think. And so, yes, personnel in terms of, the number of people working in long-term care is going to be a barrier, and also, finding the resources and time to make sure everybody has the training and so the skills and knowledge they need. But working on that and working on strategies to address that in an optimal way, as part of our implementation strategies. I see there's a question too about the Brenda Strafford Foundation. So the Brenda Strafford Foundation is a not-for-profit charitable organization that actually they're an owner-operator as well of care facilities across the Calgary area, and they are also big donors to the University of Calgary. So they fund several chairs at the University of Calgary, research chairs. One of them I hold in geriatric medicine, and they also were the initial donor that set up the Center on Aging at the University of Calgary, which I'm the academic lead of. That's who the Brenda Strafford Foundation is, and so that's my relationship in terms of them as a donor to the university and them funding both the Center on Aging I work at and a research chair that helps fund research like this.
Yeah, absolutely. And the society does have a bit of a relationship with them as well. We don't work super close with them, but definitely always in the, being in the same field and supporting the same type of families and people living with dementia. It's important to be connected. So 2 more questions, and then I think we'll wrap it up for the afternoon. How do I, or where do I point families who want to learn more about supporting their person?
Well, I would typically say Assant would be one area. They definitely, there's great resources online and otherwise. And then also, depending on where this individual is, they're within the Calgary area, we have the Dementia Network that is a great resource for families and people living with dementia as well. And there's also caregiver organizations across Alberta, the Alberta Caregiver Organization that I think has great resources. I'm not sure, those are sort of my go-to resources to direct families to.
Yeah, absolutely. I would say definitely give us a call or refer someone to us. We are more than happy to welcome new clients. And the last one is, what's the next step in this research?
So in addition to this frailty pathway, I'm actually, even from a broader perspective, I've applied for what's called a CFI, a Canadian Foundation of Innovation grant, to actually purchase a bunch of infrastructure to actually support research within the long-term care, continuing care sector, to actually what we're calling rethinking continuing care, to address not only care pathways, but also look at how do we incorporate technology, how do we look at the environment within long-term care in terms of optimizing the environment. And so those main areas. So I'm hoping that actually we will get funding, and some of these initiatives are moving forward with funding through my chair. But so we're working broadly at sort of working within the continuing care sector to really help rethink and also change perceptions in terms of the role that continuing care plays in the healthcare system, that it really valued resource, needed resource. That's sort of where I'm taking my research in terms of trying to be an advocate and supporter and supporting others. And there's a lot of initiatives going on that we need to bring together to actually, be innovative in terms of the sector. And, there was a report from the government that came out sort of shortly at the pandemic that looked at sort of the need to rethink continuing care and the provision of care, and some of that they're moving forward on, but we have a ways to go in multiple areas. So that's kind of, it's a combination of advocacy and supporting research and innovation and applied innovation. So that's kind of where I'm hoping to take, using my leadership roles, and also, advocating, using opportunities such as the upcoming election to put this at the forefront, right? The need to be rethinking continuing care and to invest in the continuing care and to prioritize it. And ideally, I'd like to see, continuing care recognized and as important as acute care, and to attract, to make it as an attractive place to work and to do research, and recognizing it's I think it's fabulous that we invest in aging in place resources and keeping people at home as long as possible, but realistically that's not always the best option for the person living with frailty and dementia, nor for their families. And so we will need options of supported environments. So we need to be building on that. And so that's kind of where I'm focusing, more and more as I go on in my career, less about my own personal research, more about supporting and building capacity to do research within this sector and to improve, the sector. I'm also branching out into areas such as trying to address ageism. And so we've done a lot of initiatives, for example, around an age-friendly Calgary and an age-friendly university within at the University of Calgary in terms of as we move forward as the population continues to age.
Yeah, and honestly, that all sounds very exciting, because I do think that we definitely need to start continuing the shift. And you're absolutely right about the election piece. This is the time to start to speak up and advocate for what's important for our future, for all of our futures for that matter, because aging is not, it's not an option, it's an inevitability. So
yeah, by 2030, 1 in 6 across the world will be 60 or older.
And that's a large statistic to kind of wrap your head around. And what does that look like in terms of care?
Yes.
Whether it's in the home or outside or in some sort of care space. So anyways, thank you so much for your time this afternoon. We always really appreciate when you take the time, especially as you support us in a lot of different areas at the Society. So thank you again for your presentation this afternoon. And with that being said, I think we'll end the meeting and see everybody in a couple months.
Well, thank you everybody for your attention and for your great questions. Have a good afternoon.
Thank you.